I am. Thanks, Russ. Thanks, Russell. Good morning, everybody. My name is Sara Dugan. I'm a mental health pharmacist and faculty here at NEOMED. For our mentor opiate echo, we have, there we go. I was having trouble multitasking. We have a schedule of rotating topics. So it's nice to see some new names because there aren't too many changes to the formulations of buprenorphine lecture that we have. Our objectives for this session are to list the available buprenorphine containing preparations for here in the US. We're going to talk about the administration differences. We're not using traditional oral formulations with our buprenorphine products, so we do have some considerations in terms of dosing. And then we'll look at some of the pharmacokinetic differences between some of the formulations. Let's get started. Buprenorphine preparations. So I split these into preparations that are available containing just buprenorphine and those that are the combination products. When you pull them up in tertiary resources, things like Lexicomp or UpToDate, you'll see a whole list of all of the buprenorphine products. So they're not necessarily going to differentiate between those that are approved for the treatment of opioid dependence versus those that are approved for the treatment of chronic pain. So I included all of them here. We're going to focus on the ones that are in the top part of this table. So the sublingual tablet as well as the long-acting injection. The intradermal implant is on here for posterity reasons. It was discontinued, so that one's not necessarily available. There had been some discussion about whether or not another company would take that up, but there really hasn't been any movement in that realm at this time. The other update I have for you is Brixadi. So the other long-acting injection, they did submit additional materials to the FDA at the end of June, and they've received a date for getting some type of response from the FDA. So they'll have information no later than December 15th of this year. So later in this year, we should have more information on the official status of Brixadi. Looking at our combination preparations, again, moving away from the traditional oral products, we have both buccal films as well as sublingual films and sublingual tablets in a whole variety of different doses, as you can see listed. So recognizing there are quite a few of those different preparations, moving from one product to the other can be a little bit confusing. The morphine equivalence was something that was requested by one of our other attendees, so I have it in there for your information. But with all of those different dosing, we need to make sure that the patients are administering the medication appropriately, especially since it's not going to be just a traditional tablet that they'll take and swallow. The ones we'll focus on are both the buccal administration of the buccal film, the sublingual tablets and sublingual film, as well as the long-acting injection. With the buccal administration, so these are going to be the films. The films do have two layers. So one layer is relatively impermeable. It's not going to let the buprenorphine dissolve back into the oral cavity. It's really going to keep it and push it into the buccal tissue. And then the microadhesive layer is the layer that's going to attach to that buccal tissue, and that's where the drug is going to get delivered to. Important that the patients clean and dry their hands, making sure their hands are dry will keep the film from sticking to their finger instead of getting into their mouth like where we want it. It may take a couple seconds for it to adhere, so ensuring that they just keep it right there, and then it will dissolve completely within about 15 to 30 minutes. Because there is that backing layer that doesn't allow a lot of the release of the buprenorphine back into the oral cavity, we tend to see less of the taste issues than what we see with some of the sublingual products. The sublingual products, we get the dissolved buprenorphine all over the tongue, so we can see more of those taste issues. So this does tend to be a bit of an advantage. Since it will take 15 to 30 minutes, to dissolve, it would be best if someone's not doing a presentation like this for the next 15 to 30 minutes when they have put it in there. We just don't want them to jostle it loose because that may affect how much of the dose gets delivered. These are instructions that will come with the product when they pick it up. So again, the clean, dry hands. And we'll talk a little bit later, trying to encourage patients not to eat or drink when they're doing this. Because it doesn't have very good bioavailability orally, that's why we can't have oral preparations. If they do eat or drink anything and it becomes dislodged, they're going to swallow it and really not get too much of that dose. Sublingual tends to be a relatively common dosage form that patients will use, sublingual films or sublingual tablets. Again, clean, dry hands, and then placing the product underneath the tongue. They can do up to 2 tablets or 2 films at a time, so one on each side of the tongue. Ensuring, especially for the sublingual products, that they do have a relatively moist mouth. So if they want to take a drink of water, swish it around, maybe they've just brushed their teeth, but kind of making sure there's a decent amount of saliva there for the products to be able to dissolve. The films are going to dissolve much more rapidly than the tablets are. The tablets will take a little bit of a longer period of time. Again, if they can avoid excessive talking, so we don't want to dislodge them, as well as no eating or drinking when they're administering this. Again, that's because it can accidentally be swallowed, and then the bioavailability. So that dose essentially will be cut anywhere from 1/3 to 1/2. With those, we really don't want them swallowing any of the products. So kind of making sure that they have them just there underneath the tongue. Last formulation that we have is our subcutaneous injection. So the Sublocade is the one that is currently available. Patients do need to be stabilized on a transmucosal product for at least 7 days. So making sure that the buprenorphine is going to work for this patient before we start the long-acting injection. These are abdominal subcutaneous injections. It's a injection of a depot gel. So once they've injected it, the gel becomes a deposit in the subcutaneous tissue, and then it slowly breaks down and releases the product over time. The prescribing information recommends 300 milligram doses for the first 2 months, and then there is the option for the 100 or the 300 milligram dosing. It's recommended that the injection sites be rotated. So you can see at least 4 different recommended sites. The deposit that's there has been reported to take some time to break down. So they may continue to feel that that deposit in their subcutaneous tissue, even a month or 2 after that injection has taken place. That's not necessarily going to hurt them. It's just going to take their body a little bit of time to continue to break that down. Just because the deposit's there doesn't mean they're still getting drug. So after the 1 month time frame, those deposits don't have much buprenorphine left in them to be able to continue to provide therapeutic concentrations. So recognizing that we have a few different options to be able to get the same medication in, how do the adverse effects compare? Are they comparable? Are they tolerated about the same? The answer is yes, for the most part. So we do see some adverse effects that we would expect. Things like abdominal pain and constipation, as well as nausea, can happen with a number of opiate products. So really not a surprise that we see them here. Headache and insomnia tends to pop up with quite a few medications, not just those used for opioid use disorder. So those tend to be ones that are seen a little bit more frequently. Withdrawal syndrome, potentially, yes, the products could cause that, but it may just be that the doses initially are a little bit lower than what the patients need. So not necessarily that it'll continue to cause withdrawal syndrome for the patient long-term. And we do see injection site reactions with the Sublocade, the long-acting injection, that is a little bit different. It was less than 10% in most of those clinical trials, but pain, redness, sometimes swelling at the site of injection has been reported. So how do they differ? How can we compare these products one to the other? So looking at the pharmacokinetics, so how the body is processing the medication. From an absorption standpoint, the buccal films are much more bioavailable than either the sublingual films or the sublingual tablets. So about 2/3 of that dose is able to be absorbed appropriately. The sublingual film is the next, so we see bioavailability of about 1/3, and then the sublingual tablets being the lowest in terms of bioavailability. The doses of each of these products have been formulated in a way to be able to overcome this. So recognizing that if we're moving from one product to another, that's where we really need to keep this in mind, because you wouldn't go from the same dose of a sublingual tablet to a buccal film, because they're going to get much more of that dose absorbed. In terms of time to peak concentration, how quickly does the medication get in there? For the most part, within the first 1 to 2 hours, they will have reached peak concentrations of the dose. And then half-life is about a day, if not a little bit longer than that. So why is that important? If we're making any type of dose adjustment, it takes 5 half-lives in order to get to a new steady state. So about 5 days later is where those concentrations will be more consistent, and we can truly see what the adverse effects are that the patient's experiencing. Are they starting to develop a tolerance to that, as well as what is the true impact of this dose change? If we were going up, is it more effective in treating those symptoms? If we were reducing it, are those symptoms still being consistently covered? So that's really the advantage of knowing what the half-life is for these products. Trying to compare the two products. So we do have differences in addition to the bioavailability. This came directly from the prescribing information of some of these products. So it's looking at the maximum concentration of various doses, comparing the sublingual film to the sublingual tablet in the 3rd column, comparing the buccal film to the sublingual tablet in the 4th column, and comparing the 2 films in the final column. So as we look at this, the sublingual film tends to result in higher concentrations of the maximum concentration than what we see with the sublingual tablet. It's more bioavailable. That film is going to dissolve much faster underneath the tongue than what the tablet does. So possibly the patient swallowing a little bit more of the sublingual tablet dose. So kind of not a surprise that we see some of those higher concentrations with the sublingual film. And looking at the buccal film versus the sublingual tablet, it's relatively, it's even more consistent. The buccal film by far achieves higher concentrations than the sublingual tablet. And then looking at the 2 films together, the buccal film has been reported to achieve higher concentrations than with the sublingual film. So if there is an instance where a patient does seem to need higher doses, the buccal film is able to achieve that a little bit more consistently than the sublingual film, than the sublingual tablet. So if we are in a situation where formulary may be an issue in what's covered by a patient's insurance, recognizing that if we need to use the sublingual tablet in a patient that needs those higher concentrations, we may need to use much higher doses than what we'd see with some of these other formulations. But not all of the formulations are exactly the same. So recognizing that we can get those different concentrations, they have identified what some of the conversions would be if we're moving between products. So as you can see, the buccal film is about half of the dose of the sublingual tablets. So they'd be on the same number, but still achieve the same concentration. From an education standpoint, that might be important to let the patient or their family or caregivers know, because they may see this and say, hey, wait a minute, you're giving me way less than what I had gotten before. Well, no, you're going to get the same thing. It's just delivered in a more efficient delivery system than with the sublingual tablet. In looking at our, not all of the sublingual tablets are exactly the same. So we do have one product that stands out, the Zubsolv. It's created using a different manufacturing technique. So they use a dry mixing and direct compression technique, as opposed to some of the just pressure compounding formulations that are used with the other sublingual tablets. These particular products are found to be lighter than the other sublingual tablets, but more importantly, they dissolve a lot faster. So by using this particular process to create the tablets, they can get higher bioavailability because the time to dissolve is significantly shorter. Because of that, we can still get the same concentrations with a lower dose. So even with the sublingual tablet formulation, sometimes we can use lower doses. It's not half that we saw with the buccal film on the last page, but it is lower than what it would be if we're using other sublingual tablet formulations. Coverage may be a consideration, but for patients where the bioavailability, we just even increasing the doses aren't able to get to where we want it to be, this may be a potential option. Oh, we are frozen. Oh, there we go. And then the last formulation that we had, I did not forget about our long-acting injectable. So what does it look like with the long-acting injectable? So we've been talking about those transmucosal products. Is this as effective as them in maintaining those serum concentrations? This also came from the prescribing information from Sublocade. So these are the average steady state concentrations, the maximum steady state concentration, and the minimum steady state concentration. They looked in a comparison for patients that were on the buprenorphine sublingual tablet at 12 milligrams daily, at 24 milligrams daily. And then these are the values for the first injection of 300 milligrams of the Sublocade. And then for patients who were given the monthly injection of either 100 milligram or 300 milligram. I'm just, for sake of time, going to do the average steady state concentration. So for patients that were stabilized on 12 milligrams daily, their average concentrations were about 1.7. For those that were on the 24 milligram, they were at about 2.9, excuse me. So with that first injection, patients on average were achieving concentrations of about 2.2. So higher than the 12 milligram, maybe slightly less than the 24 milligram, but again, they're just starting to build up the buprenorphine that's in their system. By the time they get to those monthly injections, even the patients that are on the quote unquote lower injection, the 100 milligrams monthly, had average concentrations of about 3.2. So even slightly higher than the patients that were taking the 24 milligram daily of the sublingual tablet. The one caveat that I will say, so these are the average concentrations that are achieved. There have been reports of patients toward the end of that monthly dosing interval reporting some return of symptoms. So they're feeling that the effects of the buprenorphine are wearing off. When we look at the pharmacokinetic information for Sublocade, there's a whole range on the chart that shows their, actually I might have put it on here, that shows their concentrations. I remembered. These are the concentrations and the number of days. So you see there can be a pretty significant range. For some of the patients, if they are, the 2 nanogram per ml is considered the concentration where most of the patients have their symptoms under control. Obviously, there are some patients who are able to get efficacy at concentrations lower than that, but this was the threshold that was established for the long-acting injection. There are going to be a handful of patients that are right around the 2 nanogram per ml, as well as some patients that fall just underneath that. Why? Just because of their individual characteristics. So for those that may be much closer to this line or even fall slightly underneath it, I guess shouldn't be a surprise in those patients that they're starting to see symptoms at the end of the monthly interval. There have been a couple things that are done. From an insurance perspective, it's difficult to be able to give the injection earlier. They do allow a little bit of time around that 1 month time frame to give the injection, but we may not be able to have it every 3 weeks and have the insurance company continue to cover it. In other instances, what individuals have done is provided a transmucosal product. So they have the injection, and for the last week of their injection, maybe they supplement with a sublingual tablet once daily, just to help with that until they get to their next injection. So that has been recognized. There is a lot of variability, as you can see, with all of the patients. As we're starting to get more information, hopefully we can identify some additional factors that will help us prospectively identify the patients that really are going to fall farther down here and may not be the best candidates for the long-acting injection. So we've got lots of options. At this point, we really can't identify what's going to be the best for each patient. There are differences between them. So as we're swapping between formulations, that is something to keep in mind. And insurance definitely plays a role in what we're able to select. But the number of options is increasing. So that is encouraging. With that, I'm going to stop my share and I will turn